Thanks, guys. So I might have had a little too much fun with the theme of this presentation, but it's Saturday morning, so you're going to see a lot of memes throughout. I had a little too much fun. I just wanted to go over a lot of the things that you guys keep seeing in social media. People keep telling you what exercises are great for knee pain, so we're going to have fun with it today. First off, though, a big thank you to each and every one of you guys that came out 8 o'clock this morning. I appreciate it greatly. And then, of course, Perform Better for putting on these amazing events. So like Chris said, I have been a physical therapist for almost 20 years now, a little over 20 years now. So when it comes to the knee, you name it, I've seen it. So hopefully I can share a lot of what I've learned along the way. Sorry. I won't bore you with all the statistics. We know knee pain is quite prevalent. A lot of people have knee pain. I'm sure all of you guys in this room have experienced it, or you're working with people with knee pain. It's one of the most common complaints in primary care setting, and I can tell you from experience, usually when I get someone that comes to see me with knee pain, it's not just knee pain. It's my hip hurts, my back hurts, everything hurts. So it's usually a combination of all of these things. But that third bullet point I want to hang out at for a minute. Almost half the population is going to experience osteoarthritis. And so that's that wear and tear, or the bone on bone. And these are really challenging individuals to work with because a lot of movements hurt. Squatting, lunging, step up, step downs, right? We've all had those clients that say, I have bone on bone. We are going to spend some time here because it is quite prevalent. And a lot of the research is based around individuals with osteoarthritis. So you're going to see that come up a few times today. Fun facts, you have to have some fun facts this early in the morning. It's the most stressed joint in the body. A lot of stuff can go wrong. The second fact, that was kind of fun to find out, it can be used as a biometric, your kneecap. So everyone in this room has special kneecaps, kind of like your fingertips and the retina in your eyes. And the last two are the key points for today. So knees are one of the most complicated joints in the body. It is not a one-size-fits-all approach. It's not do these 3 exercises and your knee pain is going to go away. It's not that simple. And then that bottom point, knees rely on several muscles to function. You guys know this, but I do not see it played out. I see people trying to isolate individual joints, individual muscles. It's more about how all those muscles work together. So that's what we're going to talk about today. So what does it mean to have healthy knees? It can mean something different to each and every one of you guys in this room. It means something different to all my patients. So it can be getting back to sport, just doing your hobby, walking without pain. For those that don't know, I live in Vegas, and when I first moved there, I would ask my older populations, I'm like, what's one of your goals? What do you want to get back to doing? And they're like, I want to get back to the casino. And for those of you who know Vegas, that's getting in a lot of steps. You need a lot of stamina, a lot of endurance, and you need to be able to walk. So it can mean something different to each and every person. It does not mean to do a certain exercise. Everyone keeps thinking that we have to be able to do all of these exercises in order to have healthy knees. You don't have to do one exercise. Everyone that keeps thinking you have to do sissy squats or lunge with your knees or your toes. No, you have to do what's most appropriate for you and what your needs are. All right, I pulled this just from the health and disability model, just so you guys can see the cycle of what happens when someone does have a lot of knee pain. So this is, of course, osteoarthritis. So we start to have body structure function impairments, so a painful joint. We start to have decreased range of motion. Then we have limitations in activity, like difficulty walking, difficulty performing movements like squatting, lunging. And then we have activity restrictions. We don't go to the casino anymore. We don't go to the gym because everything hurts. And when we have osteoarthritis, something like that, it's a chronic pain issue. And we're not going to touch on chronic pain, but there is a ton of new research coming out on chronic pain. And there is a whole psychological component when we have that. There's the stress, the anxiety, the fear, all of that comes with that. So I just wanted you guys to see kind of the spiral effect of what happens when people do experience substantial knee pain. So lots of factors can impact knee health. This is just the short list. We already went over osteoarthritis, lack of physical activity. I can tell you I see a lot of people that are the ones doing too much as well. That happens quite often. One of the main things that we're going to talk about most today is that foot, ankle, hip, pelvis, and core. So we're going to dive into that a little bit later in the lecture. But that's one of the biggest things that impact knee health that we often don't think about when we're working with individuals with knee pain. So a lot of common knee injuries. I'm not going to go through every single knee injury. Remember, it's one of the most stressed joints in the body. A lot of stuff can go wrong there, and you can have overlapping things occur. We can have ACL tears with meniscus tears and so forth. I have an influx of fractured patellas now, and those are really tricky to treat because they take a long time to heal, and range of motion is really hard to get back. Now, this was really interesting too. Individuals with a history of knee injury, 3 to 6 times more likely to experience osteoarthritis of the knee. So if you're in your 20s, you tear your ACL, you're more likely to have osteoarthritis earlier in life too, like maybe in your 40s instead of your 50s and 60s. So previous injury is also a risk factor for a lot of things when it comes to the knee. So osteoarthritis is the most common form of arthritis in the knee. That's why we kind of keep talking about it, because it is really common. We have lots of different grades. So it doesn't necessarily mean bone on bone. We can have mild, mild to moderate, severe. I think people think it just means bone on bone, but there are varying degrees of osteoarthritis. And I hate the term bone on bone. So any patient that comes to me that says, I have bone on bone in my knee, why am I even here? There's nothing you can do. These individuals feel so defeated. My husband and I, we were working with the Las Vegas Raiders, which sounds weird to say right now, Las Vegas Raiders. And they were the alumni, but they ranged anywhere from 30, all the way into their 80s. And we were listening to them talk before we were going to talk about chronic pain. All of them, all they kept saying, bone on bone, I gotta get surgery, everything's bone on bone, there's nothing I can do, I can't do this, I can't do that. It's very defeating for individuals. So we need to change that language and sit down and educate them and say, hey, there's lots of research out there, there's lots of things that we can do, there's lots of ways that we can help you, and kind of reframe it and say, hey, it's just, it's moderate to severe, there's still things that we can do. So hopefully we can stop using this, because most of the time people just think it's a waste of time to go to the gym or go to physical therapy or any of those things. So this was actually a quite interesting study. It was a large group, 180 people over 24 months. So there was 3 groups. There was a lavage, a debridement, and a placebo, which doesn't really happen. You don't have placebo surgeries in research too often for ethical concerns, so this was really interesting. Those individuals thought they had surgery. They went under, they had an incision, they thought they had knee surgery. And what they found was that the lavage and debridement were no better than the placebo group. It's quite interesting. And then at some point during follow-up, objective function was significantly worse in the debridement group. Objective, range of motion, manual muscle testing, gait. I'm not talking about subjective. So this actually set the clinical guidelines for surgical intervention for individuals with osteoarthritis, this study. So they don't do these types of surgeries anymore because they're not really effective. What tends to happen is a total knee replacement later on when you have that much damage. Mechanism of injury, we're not going to go through every single one, but I think it's important to note just so you guys understand the complexity of knee injuries. So we have the non-contact, that deceleration, acceleration, that tends to fall under where you see those ACL tears. Contact, we've all seen people out on the field take a blow to the knee. High energy trauma, falls, motor vehicle crashes. Extrinsic factors, we don't really think about either. So training surfaces, shoe wear, all of these things can put increased force and stress through that knee joint. Intrinsic factors, muscle weakness, foot shape, all of these things can impact the knee. Now, this is your typical ACL tear, right? So you have deceleration, change in direction. Rehabilitation and pre-rehabilitation or any type of exercise can help prevent some of this. Now, women tend to have a higher rate of injury overall. Specifically ACL tears, you'll see higher rates of that, and that can be from those intrinsic factors like strength, stability, weakness. And there is one more, and I think it's lack of resources for female athletes. That tends to be one of the biggest ones out there. Now, this is important too, because I keep seeing people get pressured into getting their athletes back on the field, getting their patients back to doing everything they need. This was looking at return to play after ACL repairs. All patients who returned to sport before 5 months suffered a knee injury. That is not really good odds getting them back on the field that quickly. 100% of them, and it was a big group, and they were all, I think it was soccer, volleyball, they were all athletes. So pressuring your clients or your athletes to get back on the field doesn't make sense whatsoever. Even at 9 months, you're still at a high risk for re-injury. And 9 months is kind of that mark where you try to get back out on the field, but they're still seeing a lot of re-injury. So remember, previous injury is a huge risk factor for future injury as well. So I don't want anyone to feel pressured to get people. And that goes for anything, like hips, knees, backs, everything. I keep seeing people like trying to jump on these, new knees and hips and everything. You just got to let things heal for a while. Type of injury matters. So there is no one-size-fits-all approach, contrary to everything you see on social media. Everyone's going to tell you they have a protocol to fix your knee. You have to do these knee exercises. No, you don't have to do a single exercise. You have to do the right exercise for that individual. So the injury type is gonna matter. Obviously, if we have a sprain, a full tear, all of this is gonna dictate the protocol for the rehab process. Severity, you can have strains, sprains, full tears, things like that you have to take into consideration. Was there a surgical intervention? That's gonna change everything with the prognosis and the time back getting to their normal activities. Individual factors, we know the older you are, the longer it takes to heal, the more sedentary you are, the longer it takes to heal. So all of these things dictate kind of how we're gonna approach that exercise prescription and application. Now, on to the fun stuff. So I wanted to kind of give a background to, or an origin story to all of these exercises that you guys see on social media. So hopefully I don't offend anyone, but I want to dive into all of this because I see it too. So I want you guys to understand where they came from, and I want you guys to really kind of choose to see if they're really that great of a knee exercise or not. So first off, I know you guys know this, but for some reason I don't see it played out very often on social media. The most liked and shared content has the lowest evidence. So even if someone has millions of followers and they say this is a great knee exercise, you still have to ask why. Why is this such a great knee exercise? Instead of just taking it, giving it to your client the next day and doing it. So that's all of the research, even looking at necks, back, shoulders, hips, like it is not good content out there. Now, I want you guys to ask the why behind exercises. I don't want to give you just a bunch of exercises. I want to give you better solutions to work with individuals with knee pain. So understanding the intent and the purpose is key. If you don't know why you're doing a certain exercise, you have to take a step back and ask yourself, what is this exercise doing? What is the intent behind it? And what is the outcome I'm trying to get? Not, I saw it on social media, someone said it was good, I'm going to do it. Ask the whys. Now, let's talk about knees over toes. This is a big one. For those that are younger, you might not remember, there was a time, if your knees went over your toes during squatting or lunging, your knee was gonna blow up. There was a time like that. Now we're like in this, so some of you guys remember that, right? It was like, oh, your knee can't go past your toes. And now we're on this other end where your knee should go way over your toes. And that way you're gonna have super healthy knees, and you need to be doing that in order to have good knee health. So where are we at with that? This is not to make fun of anyone, but I know this is a very, very popular video that came out, so we're gonna watch it and we're gonna talk about it, okay?
Because when you bring the knee back, the load shifts from the legs to the lower back, which isn't designed to handle that kind of stress.
But when you align these to a positive targets, that one of is distributed more it's around the legs.
This is why movements like the sissy squat, where the knee goes as far past the toes as possible, are great for lip proofing.
How many of you guys have seen that video kind of floating? No? Okay, well, it was very popular. It was very popular. So everything but the very last line that she said, literally everything they said was word for word from research. Everything they showed was not a part of the research. Not lunging with the knees going over the toes, not the sissy squats, that wasn't part of the research. But everything they said was word for word. This is the research that everyone keeps citing with knees over toes. It's from 2003, I believe, so early 2000s. So this was really designed because people kept saying, should your knees go over your toes? Should they not go over your toes? So they did research on it. So it was a barbell back squat. They blocked the knees in one, and then they allowed the knees to go over the toes. You can see the knees aren't going crazy or excessively over the toes. They're just going over the toes. This was the only movement they looked at. And so then they said, okay, well, if we block the knees, then we have these extra forces, or they're getting displaced in the low back and the hips, so it's okay to let the knees go over the toes. In a healthy knee, people with painful knees, they don't like the knees going over toes initially. It's quite painful. There's a lot of force through the knees. So they said it's fine. That's what the study was, really. So, I mean, ultimately, wouldn't it be great if we could just ask one of these researchers what they thought the research really meant? I think it'd be really cool to be able to ask them. So I did. This is Dr. Brian Schilling from UNLV. He's one of my friends. He's the one in the photo doing that barbell back squat. He was part of the research with this. I did not prompt him. I didn't tell him what this was about. I just said, hey, what do you want people to take away from this research? I don't even think he knows how many people have taken his research and just ran with it. So let's take a listen.
But targets we understand as gotten so much traction over the years. But I think the most important thing that the article shows, it's not necessarily harmful for the knees to go past the toes when you're squatting. The relationship really between what's going on at the knees and the toes depend on your body. Right? Some people have longer femurs, longer torsos, etc. And it also depends on some mobility aspects, what's going on with your mobility at the hip and on the ankle especially. So the location of the system center of mass is also going to change based on all those different lengths that you have. So it's not just where the barbell is. We talk about the differences between front squat and back squat, where it's just also just, how far away from the body surface that barbell is, where those two center of masses kind of come together, what that system does. So likely the most problematic issue, even though it's not something that we should there in that study, is whether or not the gaze and your toes are in the same plane. Right, so if you get a lot of valgus where these are coming in or they're going out, probably more problematic for knee health than is the relative position of the one that they stay in that same plane. Your knees do affect your toes.
So nothing really about how far that knee should go over your toes. And remember, I didn't prep him. If I prepped him, he probably would have said something a little bit different or kind of dove into what the discussion really was about. But he was talking about really what was going on at the hip and the ankle, and then more about the knees in line with the toes for that varus or valgus. So it had nothing really about how far your knees need to go over to your toes. So it was really nothing what people keep showing on social media, because this is the research that people take and they throw it up and they said your knees should go over your toes when you're doing all these things. That wasn't what the research was showing. Now, wedge squats. This is a very popular exercise here in the States. And I say that because, funny story, I was speaking in Tokyo and I had a whole section on squatting and wedge squats, and I just kept babbling, and then the interpreter's like, hold up. And she runs out into the audience. The audience had a couple hundred people there, and she's talking. I'm like, did I just say something offensive? Like, what's happening? Did something not translate correctly? What's going on? And she runs back and she's like, they have no clue what you're talking about. They do not do wedge squats. This is not a thing. So this has only kind of been popular in the United States right now. So people say wedge squats are good for knee pain. Where did this come from? Came from this. So this is decline squats. It was for a very, very specific pathology, which was patellar tendinopathy. And they looked at improving patellar tendinopathy symptoms through decline squats. This is the research everyone takes when they talk about wedge squats. So this was a very specific protocol with a very specific pathology. So 3 sets of 15 reps. It was twice daily, 90-degree maximum depth. We're gonna see that change in one of the slides. It was single leg. And then the concentric phase was performed by the opposite leg or the unaffected leg or both legs. So very, very specific protocol. And this, they changed it to about 60 degrees versus 90 degrees because at 60 degrees you get more patellar tendon share. So they felt that that was a good angle because that's what we're aiming for with patellar tendinopathy, is to get a lot of stress on that patellar tendon instead of that 90 degrees. So it's starting to look very different than the wedge squats that we're seeing all throughout social media. It's also a very painful exercise to do if you actually have patellar tendinopathy. And I don't know about you guys, but if I have a patient or a client and I give them a painful exercise, they're like, I'm out. It's not really easy to do. Yes, some athletes are willing to do it, and that's fine. But this was really the protocol. And then we took it to this. So this is a lot of the, they'll say wedge squats are great for your knees, so therefore we did this. We did a bilateral front squat, heavily loaded, full depth, all of that. So not the same thing at all. But what they also did was compare it. So we always have to look at studies and say, did they compare it to something? So they did decline squats with corticosteroid injections into the patellar tendon, and then they compared it to heavy, slow resistance training. Heavy, slow resistance training had better short-term and long-term outcomes and improvement in collagen turnover. And it was not a great heavy, slow resistance training program. It was a back squat, hack squat, and leg press. Imagine if you had a really good heavy, slow resistance training program. So that beat wedge squats, but no one ever talks about that. Everyone just says wedge your squats because it helps your knees. And don't worry, I know you get more quad with wedge squats. So I always like to ask the question, how much quad do you need in these exercises? And no one can ever tell me the answer to that. And yes, you can see you do get more hamstring and quad with a decline board squat. Look what happens to the lower limb though. That tibialis anterior goes way down. The activation of the lower limb goes way down because you take ankle dorsiflexion out of the equation. Ankle dorsiflexion activates the tibialis anterior, so you're removing a joint. The trade-off doesn't make sense when you really look at it because no one can tell me why I need more quad than I do the lower limb. The lower limb and the foot are key in helping knees. You remove that, you're not really doing a great squat for your knees. What about the VMO? Everyone's just like, well, we need more VMO, we need to isolate the VMO, all of this stuff. But you can't preferentially isolate these muscles. That is what the research is saying. You just can't. And then I'll also add, people say they like the wedge squats because you get full range of motion, but you're not going through full range of motion if you're eliminating the ankle joint with that. And people will say I'm doing it as well for ankle because they're lacking ankle mobility. I would still like them off of the wedge, working on foot stability, working on the lower limb, and decrease the squat range of motion versus put them on wedges for that. I want to address the ankle mobility as well. Again, it was concluded that closed kinetic chain exercises do not preferentially recruit the VMO. So I just wanted you guys to see some research that says trying to isolate these muscles just really isn't a thing. And if you look at the anatomy, it's nearly impossible to isolate these muscles. It really is. If you look at real human anatomy, in order to isolate these muscles just isn't possible. Now, reverse Nordic curls, this is another popular knee exercise because of the quad activation. But again, they compared it to something. And I'm sorry, if someone has knee pain, I'm not getting them in this position. Every time I show like a half kneeling or a kneeling exercise, people are like, no, we can't get them in this position, but you're gonna get them in this position? So this is really hard to do anyway, and it's not a great position for people that actually have knee pain. Usually the people you see doing it don't really have knee pain, but it didn't really do any better than a single leg squat, rear foot elevated, and a split squat. Didn't do any better. So if your argument is it gets more quad, it doesn't actually. And this one is more of a kinetic chain exercise where we have more body integration than the other one. So I would choose a more integrated movement over something, and then the argument's not there anymore for more quad. All right, so Spanish squats are really having their moment in the fitness industry right now. I am seeing all the gyms add in Spanish squats. Let's talk about where this came from. This is from the rehab world. So we started to do this because it took pressure off the knee, right? The knee isn't going over the toe. It's not going forward. We're not having a lot of force through that knee joint. So people that were post-op, that had really painful knee joints, you weren't taking a lot of pressure in that knee, and you had some of that artificial stability through the band, helping you with that squat. I personally don't use Spanish squats, but that's what they were there for. And then I've had people kind of yell at me and say, well, for tissue extensibility, and there's a lot of ways you can get tissue extensibility as well. You don't need to do a Spanish squat for that. So started from the rehab world, but it went into the fitness world because you get more quad. Everyone wants more quad. So this one gets more quad, yes, but what's the trade-off? The glutes and hip abduction. And those are key components in good knee health. So I just want you guys to start seeing where some of these things came from, why people are doing them. Are they great exercises? Are they not? I'm seeing this on social media too. Now we're wedging Spanish squats. These two cancel each other out. They do. That tells me people don't know why they're doing these exercises. They heard wedge squats are good for the knees, Spanish squats are good for the knees, let's do them both. That makes no sense because the wedge squats were supposed to add force to that tendon or get your knees over your toes. Spanish squats are supposed to take them away. It took me forever to get in this position too. This was just a crazy position to get into. It's not comfortable. Would not recommend that. All right, so this one is really looking at, whether or not we should prioritize EMG, higher EMG activity exercises. And I've talked about this, if you guys have heard me talk in the past, we really shouldn't prioritize these. They're finding out that it just doesn't make sense because I've said this line before from Gary Gray, and it is Is the muscle singing or screaming? When you have high EMG activity on a muscle, that muscle is screaming at you. It doesn't mean that it's working in synergy with all the muscles around it. So I want to stop putting these exercises on these pedestals, the ones that, this one has the highest VMO activity, this one has the highest glute activity, this one has the highest tibialis anterior activity. I don't care. I want to know how all of those muscles are working together. And lots of research is coming out on this. EMG is great for learning and for research and things like that, but I really want us to get away from talking about like, this has the best EMG activity, so therefore it's the best exercise. Now, this one was talking about how strength really isn't a predictor, and I think people always think you can fix everything by just getting stronger, and that's not the case. This one was looking at quadricep strength and hamstring strength in individuals with osteoarthritis, and it really wasn't a predictor of anything. Like, the strength didn't really matter. It was really about the timing and the sequencing of all those muscles working together, not the strength of one individual muscle. And I liked this quote from Gray Cook: absence of motor control mimics weakness, but strengthening the stabilizers is not a solution. It's really not about what muscles appear weak, because muscle weakness is a byproduct of injury. Usually people are not getting injured because they're weak. I'm not saying it doesn't happen, but the majority of the time it's not because your quad was weak that your knee got injured. So I want people to understand and get away from that focus of strength so much. It never fails to, because when I talk about integrated training versus isolated training, the one question I get is, well, when do you do isolated training? I don't. I rarely do. Rarely. So I wanted to put this study up here. The integrated program was able to successfully improve movement quality, speed, agility, strength, endurance, flexibility, and power, compared to the isolated group, only power and flexibility. So why would I choose isolated training over integrated training when I can improve all of those things? And if you read that bottom line, strength and power exercises were in a single plane. Single joint, single muscle exercises are usually only in the sagittal plane. You don't really move outside of there. You're not in the frontal plane, you're not in the transverse plane, you're not multiplanar work. Usually exists in the sagittal plane, and that's an issue as well for anyone. And that has to do with proximal stability and neuromuscular control, leading to more efficient force production by the larger muscles. So we're incorporating a lot more of those muscles that give power and stability to the movement. That's one of the reasons they're finding integrated training is far more superior than isolated training. We've taken a step back. Functional training was on track several years ago. It was cruising. And then all of a sudden, I don't know if it was social media, we've kind of went back, and now we're just back to machines and isolated training. And that is not how we move and function in life. And all of the studies that looked, I didn't throw them all up here, we don't have time. These are the words and the conclusions of most of the research of how we should focus our rehabilitation, how we should focus our training. Multifaceted, integrated, global, holistic, multidimensional, a comprehensive approach. We need to look at the whole person when we're working with them. So I want to get away from the knee hurts, we just fix the knee and fix, one or two muscles around the knee. Walking backwards. This is a really popular knee exercise. Everyone says you got to walk backwards. It's good for your knees. I'm seeing people walking backwards on treadmills, walking backwards uphill. It's all over the place. So what does the research say? It's no different than forward walking. Remember, you have to compare it to something, and everyone leaves it out. They compared it to forward walking. It's the same. Same thing here. Indicated that retro walking program is effective, but no significant difference than forward walking. Multiple studies say that. So I do have to mention backwards walking takes less pressure off the knee, so it's a little bit less painful. I'm not saying backwards walking is bad. I'm just letting you guys know it's not a magic exercise that everyone claims it to be, because everyone's like, you need backwards walking in your programming. No different than forward walking. It came really from the rehab world. Like, I've used it in physical therapy. I'm not saying I never have people do any type of retro walking, but usually it's for neurological patients, vestibular patients, all of those patients that maybe have balance or instability. Yes, I'll use backwards walking for that, but I've never programmed backwards walking for knee pain patients. So I wanted you guys to know, like, they do compare these things to other things. Core stability. Core stability likes to get bashed recently, like core stability is stupid, it doesn't do anything. You don't need core stability, it's not real, it's not a thing. First of all, This is a great explanation of core stability. This is from Dr. Brandon Marcello. He's one of the founding people with Exos. Allowing for wanted movement, preventing unwanted movement. Just a really good way of looking at that. And when we're talking about core stability, I've said this over and over again, it's not just the transverse abdominis, it's not your obliques, it's the 32 plus muscles of the core, and that includes the lats and the glutes as well to stabilize that whole trunk musculature. So I wanted you guys to see the role of the lats, because not only today we'll briefly talk about it, but in the hands-on, we're gonna talk about how we can integrate the lats more. I'm not talking about isolating, I'm talking about how we can integrate the lats to improve our core training as well, because they are a huge core stabilizer, and I don't think a lot of people view them as that. So how can we incorporate the lats into a lot more of our core stability work and making that connection from the upper and lower body as well? All right, so proximal stability for resistant mobility. I've said this over and over again in multiple lectures, but those that don't know, let's just talk about it briefly. You need proximal stability, or a strong foundation at the trunk and the core, for your distal extremities or your limbs to feel safe to move. If you don't have that, that's where we can have dysfunction that can set us up for injury, that can set us up for poor movement. Everything happens from the center. We want that proximal stability. And this goes whether you have knee pain, shoulder pain, you name it. So we want good proximal stability. So this research looked at the core during squatting, a single leg squat, and they found with increased core stability, you improved knee flexion, hip mobility, and you were able to go deeper into that single leg squat because you had a stronger foundation, you had more core stability, so you were able to perform that movement. So we can take this research and start to apply it to certain exercises. So I'm using load. Sometimes people don't like to load if someone has a painful joint. Load can be a really powerful tool for feedback, even in people that have a painful body weight step down. If you give them load and they produce that stability at the core and the trunk, they're probably going to be able to do this without pain, where they would have pain when they're not loaded. So load, pulling that bag into my body, creating a lot of stability, is allowing me to go into a nice single leg squat because I feel safe to move. I need a lot of feedback because I have a torn meniscus in that knee. I just don't want to get it fixed because who wants surgery? So if I don't have that feedback and I try to do a bodyweight squat, it hurts my knee. So I need a lot of feedback. And this is a way we can start getting people to go through some movements that typically are painful for them to do. We can start loading them in different ways to create more stability or give them that proximal stability so they actually feel safe to move through some of these movements. And the last decade, more and more research is coming out about we should be focusing on core stability when it comes to knee health. I can tell you as a new therapist, someone came in with knee pain, I didn't have them doing any core work. I didn't have them doing any core stability work. I just worked on the knee. I tried to get the range of motion. I worked on the quad. I worked on the hamstring. All of that. So we need to start incorporating core stability with a lot of our knee clients and a lot of the knee patients because it is a predictor for injury. Remember the other slide, quadricep strength and hamstring strength wasn't a predictor. Core stability or neuromuscular control of the trunk is a predictor in injury. So this is something that we can work on with individuals. This again was just talking about the benefits of, making sure injury prevention as well. This is a great way that we can help reduce a lot of injuries, or we can help with the rehab process as well. This was just looking at ACL reconstruction. And I know people are like, I do core stability and it doesn't work. In the hands-on, we're going to talk about why that often fails. Because body weight core stability is almost the highest level of core stability. There is no feedback. You don't really know what you're supposed to be doing. The intent is missed in a lot of these movements, and that individual doesn't know what's supposed to be happening. But they did get okay effects with this. I'm not a fan of this core stability work, in my opinion. There is some of the McGill Big Three, like the side plank, the bird dog, the curl up and stuff like that. But we're going to talk about how we can improve upon core stability in the hands-on. So this is interesting as well. We're back to osteoarthritis. This was a 6-week core stabilization program with individuals with knee osteoarthritis. So these are the clients that come to you and say, I can't squat, I can't lunge, everything's painful. And you're like, what am I supposed to do with these people? This was amazing. They had huge functional outcomes, decrease in pain, and it was just core stability. So they treated the knee without really treating the knee. So these individuals, if you get them to feel better, move better, they might be able to start doing more in the gym as well. So this is really interesting. You could sit down and say, hey, we can work on core stability first, get you moving a little bit better, and then we can start to try the other movement patterns as you start to feel better or safer. People won't mind doing this for 6 weeks if they start to feel better. So this is really interesting to see as well. So the focus really needs to be a kinetic chain approach, which I've talked about. We want that integrative approach. We want the foot, the ankle, the hip, the pelvis, all integrated into our exercises as much as possible, because those highly affect the knee. Because if we only just treat the knee, we're gonna miss the bigger picture, because we're only treating symptoms and not really the cause. And I know you guys aren't all clinicians. This is still applicable even if you're just coaches, trainers, personal trainers, you name it. We need to look outside of just the area of pain. And I'm not saying you have to diagnose people. I'm saying if you kind of focus on everything, you're gonna check a lot of boxes and help a lot of people out. All right, so for those of you who know, this is Josh Hinken. This is my husband. He's at one of the Perform Better Summits. And I wanted you guys to kind of see how core stability can help in an individual and how a lot of feedback can be very beneficial to someone with knee pain. So she's trying not to have a total knee replacement. She has a very painful knee. He asked someone to come up that just can't squat. And she's like, I've never squatted without pain. So he's going to have her squat. You're going to take a listen. First time ever, no pain. See if that stops. All right, so what happened there? She had a lot of feedback. So a lot of core tension, a lot of core stability. So as she's going to push that bag out, she has to brace, create that proximal stability. She's making the connection from the upper body to the lower body. You notice she's out of her shoes and socks. She's creating stability into the ground. And that band is just giving her a little bit of feedback to get a little bit of a hip abduction. So just a band and a bag and just a few cues, she's able to go into a pain-free squat when she's never been able to do that. It's pretty cool that we can help people that normally can't get into these positions just through some load, just through a little bit of feedback. Now, this is how I would progress the squat pattern. I just wanted to show you guys how I would progress. So this is a progression. This isn't variations. These aren't just different exercises thrown up here. This is a way how I would help someone kind of get through the squat pattern by different loading positions, different implements. So remember, those are variables as well. So how we hold the implement, the type of implement, not all load is the same. It creates a different feedback to the body. So I want you guys to kind of value the tools that you have, because you can manipulate these to really get people to move better. So you guys saw the press out squat. Carrie's gonna go through how I would progress. So the most amount of feedback to the core, and we're gonna progress to the least amount of feedback. I'll let you guys kind of watch through, and we didn't even manipulate the body position, and that's another variable that we could add a layer of complexity to as well. So I'll address the elephant in the room. Where's the barbell? The barbell is going to have the least amount of feedback to that individual, regardless of if it's placed in the front or the back. You can't create a lot of stability using that tool. So that would be the hardest movement, I would think, for a squat. So someone with painful knees, I would never start them with a barbell squat. There is just no feedback with that. So obviously I didn't throw that in there, but I know someone was gonna probably ask the question. So onto the foot and the hip. The knee is a really dumb joint. It does what the hip and the foot tell it to do. Those two areas dictate a lot about what happens at the knee, and they get overlooked so often, especially in the clinical setting. We don't look at the foot, we don't look at the hip. So just as an example, if you're lacking knee extension, it can be because of ankle dorsiflexion and hip extension. If you're lacking knee flexion, it can be because of ankle plantar flexion and hip flexion. We have to be looking at the joints above and below. They really do impact knee health. And we need to be choosing exercises that incorporate all of these areas, the hip, the knee, and the ankle joints. That's the kinetic chain as well as the core. So something like a squat, as long as we don't wedge them, It's going to incorporate all of those things, right? Because if we wedge the squat, we're taking out the foot and ankle, and we're going to miss that kinetic chain versus a seated quadricep extension, which people do all the time to get that VMO, to get the quad and things like that. So our focus really should be on kinetic chain rehabilitation. And when we talk about the hips are really important as well. Restrictions in hip internal rotation. So that's the one that tends to set people up for knee injuries when we have limitations in hip internal rotation. Obviously, limitations in hip external rotation can occur too, but mainly it's with internal rotation. And I should add, if you have excessive mobility as well, that can lend towards knee injuries too. Again, this was looking at limited hip rotation and ACL strains. So there is a big correlation between lack of hip mobility and knee injury as well. I did not ever look at hip mobility when I was a new therapist, when people had knee pain, or when my athletes came in. I was not looking at hip mobility, and this is a really easy one that we can address pretty quickly too. So another area that I see people deficient in too is that posterior lateral hip musculature. So that's going to control the pelvis and the pelvic alignment in single leg stance, and control hip rotation in the frontal and transverse planes. So frontal plane stability. This is where everyone lacks a lot of strength, a lot of stability, and a lot of neuromuscular control. It's not necessarily just strength. There is a strength component there, but there is a stability and a neuromuscular control component when we're talking about this. And this is primarily where people fail, and where I see a lot of people fail with their programming as well. We're not programming well in the frontal plane. We're not programming in the transverse plane very often. We pretty much live in the sagittal plane with a lot of people's programming. And we need that frontal plane stability because injuries like this occur if we're lacking that, right? We have that excessive valgus of the knee. We have that collapse of the knee in single leg stance or in a bilateral stance when we go to pivot, when we jump. That's what's supporting us, is that musculature, that posterior lateral musculature that we need to be focused upon as well. So we can work frontal plane very easily. I'm just going to give a few examples, but in the hands-on, we're going to do a little bit more. So obviously side planks, we're resisting the frontal plane. This is a great starting position. But I always want to see how I can incorporate the upper extremity as well and tie in the lats. Remember I said the lats are a key core stabilizer. So how can we get the lats involved so we get that lat core connection as well? If people can't do a side plank, half kneeling is a good position to get them in, or this is a progression as well. I think people forget half kneeling position, you're resisting that frontal plane. It doesn't have to be huge leaps. But just in that position, you're resisting the frontal plane. I can go into something like an overhead press. It doesn't have to look like, hey, this is a knee exercise. No, if I know frontal plane stability is an issue, I can do something like this as well into my programming where I'm focused upon that. I'm also focused on creating foot stability, which we're going to talk about in a moment as well. I can get into standing positions and postures. So I'm working on frontal plane stability. I'm working on pelvic control. I'm working on core stability because as I press that band out, I have to create core tension. I have to maintain good pelvic alignment. I have single leg stance. I have foot stability. This is a knee exercise because it's working on that entire kinetic chain. This is from Fitness Lying Down in La Crosse, Wisconsin. We have the owner here today. But you can see normal people can do this. I don't know if you guys can see, there is an anchor point and there's a band pulling her even more. So this is a little bit more advanced frontal plane work where she's really trying to resist the pull of that band, and she is going into that march, where a march is a great pelvic control, single leg stability exercise as well. We have Shannon here. I love going inline as well for frontal plane stability. So we're working on foot stability. She's resisting that frontal plane. She's doing higher level core activation, more reactive core work. Obviously, this is a little bit higher level, but we can go inline for a lot of different movements and work that frontal plane stability. I don't see people doing that very often, and it's an easy way to focus on that as well. This is Corey. We can go into a sprinter stance, right? So we can get out of that bilateral stance, go into a sprinter stance, and that also is where we have to resist that frontal plane too. And these are subtleties because it's a system of movement. So we wanted to have subtle changes in that stability demand as well, but he's got a lot of core stability in that bear hug position too, so he can go into that squat really well. Now, the glutes are important. Again, I don't want to get super hyper focused on one individual muscle, but yes, the posterior chain is important. Yes, strengthen the posterior chain. There was a time where initially where people had knee pain, all the focus was on the hamstrings and the posterior chain. And somewhere along the line, it became the VMO. Like there was even equipment that you would put on, like a brace, and we would run people through these different hamstring exercises that tried to isolate all the different fibers of the hamstrings. And that's all our knee patients got. They put on the brace, you do all these hamstring exercises, you do all your glute exercises, you go home. So yes, glutes are still important. They help control that pelvis as well. So we do need to focus on those. But everyone tends to think, again, like something like the hip thrust is your go-to glute exercise. And that's not the case. Again, EMG can be really helpful for a lot of things, and I don't want to get too focused on it. But look, step up, lateral step up, diagonal step up, crossover step up, all beat the hip thrust. Nobody likes to do step-ups for some reason. I walk into gyms all the time and they don't have adjustable steps. They just have people stepping up onto benches and plyo boxes and stuff. An adjustable step can be really amazing tool in your clinic or your gym because people just don't do step-ups or step-downs correctly as well. But these are better exercises, again, because they're getting that kinetic chain, right? They're more integrated in nature. So hopefully you guys can start programming step-ups and step-downs over hip thrusts when we're talking about glutes. And this is a way you can do it in the gym, right? So they're out of their shoes. We're talking about foot stability. We're going into that step up. This is a little bit higher level. As they pull the handles out in the bag, you get that lat involvement. The bag is rotating around their body, so they're resisting transverse plane, they're resisting frontal plane, and moving and stepping up in that sagittal plane. So a very dynamic step up, but we're connecting the upper body, we're connecting the core, we're connecting the lower body as well. These are some athletes out of Laverne. The shoulder position is one of the hardest positions you saw in that progression of squats on the body. It's really trying to pull you over. So you have to resist that motion. So obviously this is a little bit higher level, but I wanted you guys to kind of see where this can go in universities with athletes and so forth. The way we load the body too, we can load in diagonals. That's how we move. So we can load in more of an X pattern, doing a crossover step. I like to do a balance step because it really forces you into hip extension and to really own that movement. And again, we're working on single leg stability and stance when we kind of go into that balance step. But there's ways to regress and progress any of these movements. Now the foot, when the foot hits the ground, everything changes. It really does. The foot is so key when it comes to the knee, and that's why I'm adamant about some of the wedge squats and things like that, because the foot is so important. This is all the bad stuff that can happen if we have limited dorsiflexion, right? So we need to be looking at that foot and ankle. It's really important. You can have hamstring strain injuries. You can have increased dynamic valgus, increased ground reaction forces and a loading. That's in a bad way. That's not a positive way. So they mean in a bad way, because I know some people want increased ground reaction force. So that's meant in a negative way. So this is where you can get, just kind of that, oh, the front of my knee hurts a little bit, or you can end up having big injuries if we are lacking a lot of that. And this is just the research that's going to back that up as well. Reduce ankle dorsiflexion, patellar tendonitis, ACL injuries, ankle dorsiflexion, dynamic knee valgus. We have that collapse. That's where we get a lot of injuries to occur from too. So the research is there. It's just nonstop. I just wanted to put a bunch up here, but pronation and supination at the foot, excessive pronation and supination. Remember, some of those intrinsic factors was foot structure. So your foot structure is key as well. And everyone has a degree of supination and pronation. I'm fine with that. It's just excessive, and especially if it's more on one side than the other, that really could set you up for injury as well. So when everyone does band exercises, or you guys have all seen this, where everyone puts the band around the knee and you got to pull it out or you got to pull it in to challenge the movement and get people in these positions so that they can lunge without knee pain. I'd rather focus at the foot. So I want to give feedback to the foot. I want that individual to create stability at the foot because a lot of people don't know how to do that. So I can use bands. The band around my foot isn't challenging the movement. It's telling me to plant my foot. And as I slide back, it's kind of guiding me and giving me even more feedback to where my foot is. Again, gripping the ground with my foot. All of these movements, I have that load giving me some stability in one shape or way. Going into diagonal patterns, lifts and chops. So using these different tools as feedback can be very beneficial to get people to move into something like a lunge where people usually have a lot of knee pain. That means they need more feedback. How can I give them more feedback? Whether it's through the core or whether it's through the ground, through foot stability. Same here for a step down. That press out, again, I'm getting a lot of core tension. That band is giving me some feedback and a little assistance as well. So this is a way to get people to do step downs with a little bit more feedback. Band under my foot, pulling the handles apart. I get the lat core involvement as well, going into what we call our max lunge, but I have a very active foot. Bear hug squat, band around the feet. People kind of like, I don't know, some crazy stuff happens when I show the band around the feet. It's just getting me to grip the ground with my feet. It's not trying to get me to go into eversion, inversion, any of this stuff. It's really just trying to have an active foot. And it's a simple thing that you can add to people to get them out of their shoes, add the band around and just say, keep some tension on that band, grip the ground with your feet. They're gonna get a lot more stability through the ground up. Now I do wanna tell you guys, there is a difference with tools. You have to understand what that tool is gonna give to the exercise. So I'm not saying this is a bad exercise, right, with the dumbbells. It's just counterbalance. I'm not giving myself any core stability. I'm not giving myself really any feedback at the trunk. It's just kind of counterbalance versus getting into that press out. I'm creating tension the entire time. So they're very different. One is not better than the other. It just depends. Like if you're going to get someone with knee pain to be able to do these exercises, they're going to need more feedback. Same with this one. Not necessarily bad, but it is more of a counterbalance with that. I'm not creating a lot of tension or core stability through holding the implement that way. So we can go into these different positions and postures. We can work on single leg stability, more neuromuscular control at the hip muscles. This, you can see I'm struggling with this one. I'm trying to really create some tension with the foot, and I'm going in different planes of motion too. So I'm getting more triplanar hip movement as well. So I prefer this as a better lateral band walk. So we can take an integrative approach to hip mobility, foot stability, ankle mobility, and addition of core stability. So all of these things together. So I'm creating a lot of tension, core stability. I'm going into some ankle dorsiflexion. I'm getting some hip mobility, some flexibility as well. So this is different than just holding a kettlebell down, which I know is a really popular exercise, and that's fine too. But if I know an individual is lacking core stability, doesn't know how to brace, that kettlebell is not going to give that to them. So I can put the load in a front hold position and really pull that in and know how to create that tension. So there is a difference, which I keep seeing people just interchange tools. But as a clinician, I love that I have tools to choose from because I can change them out in different ways and give people different feedback to parts of their body. Another way that we can work on hip mobility, and the model's here too. Foot stability, ankle mobility. The band is just telling him to kind of plan. I'm not doing like any joint mobs or really anything like that. It's trying to pull him back so he has to push into the ground. That's why I'm utilizing the band. But again, we can work on breath. We can work on core stability, hip mobility, ankle mobility, foot stability all at once instead of just I'm going to do my ankle mobility over here, I'm going to do my hip mobility over there, and then I'm going to do my core work over here. What an easy way to get the body primed to move. We've got core again. This is much more dynamic in nature, so you get more of a metabolic effect, but we're still working on that hip mobility, the core stability at once. So I do like wedges, but I'll use them to help me with some ankle mobility. So again, using the band, telling me to kind of press into that wedge. I'm going into some ankle dorsiflexion. I'm adding in some of that trunk. I'm getting some shoulder mobility as well, core stability, hip mobility, a little bit of everything at once, taking a little bit more integrated approach to ankle mobility. So I'm in the front-loaded position here. Again, it doesn't have to look like a knee exercise. So I'm creating a lot of that core tension. I'm in that split stance, which is challenging my stability in the frontal plane. This is a good position to get people in when they can't lunge as well, because it is really working on that stability aspect. I'm getting some thoracic mobility. So we can take a more integrative approach to all these mobility drills. So people always ask me, what about? What about all of these things, right? I mean, they're great if they get the pain down, if they help decrease pain. I don't care if it's placebo effect. I don't care if it's a real effect. If someone's pain levels drop, you can do more with them. So I'm okay if you guys like to use all of this. I use modalities all the time, but I'm not too focused on them because I know it's just kind of a Band-Aid. I'm not really focusing on the foundations of what we should be focusing upon. So if you're not screening, you're just guessing. So screens. I talked about a couple things that we should be looking at, but with screens, I always tell people if it doesn't change what you're going to do, don't bother screening. Now, I know people get caught up with trying to diagnose. Screens aren't meant to diagnose. We're just looking to see if we've got some issues going on, if there's areas that we need to work on. It's not telling me why that's happening. It's just showing me an area that I need to focus upon. It also is going to tell me when I need to refer out if there is a big issue going on, whether it's to a medical doctor, a clinician, whoever. It's going to tell me where I need to refer out. And then screens are meant to be really easy to repeat and recheck and see how we're doing with everything. So ankle mobility we talked about. I know there is a million different ankle mobility screens out there. This is just one of many. I'm okay with whatever one you like to do. I just wanted you guys to kind of remember we need to be checking ankle mobility. I worked in a fall prevention clinic and every single person that came in was lacking ankle mobility. And that will put you at a risk for falls as well. So not only a risk for falls, I've already shown you that it can be at a risk for knee injuries as well. So this setup, we're about 5 inches away from the wall. You're in a half kneeling position. Front foot, back foot is firmly planted. You're just gonna ask that person to see if they can get their knee to touch the wall. I want it as close as possible. Some people aren't gonna be able to touch the wall, but I want it pretty close. What I want is the same side to side. That's what I'm most concerned with. If I see a big deficit from one side to the other, then I need to know that I really need to work on ankle mobility. And again, lots of different ways we can check for ankle mobility. But we don't want that heel to come up off the floor. We want that foot firmly planted. And we just want to kind of lean into the wall without having to arch your back or be too aggressive with the movement. We're just seeing if we can get that range of motion and what that looks like. Step down. I like a lateral step down because remember I told you that forward step down, if someone has knee pain, it's going to be painful. They're not even going to be able to do the screen. So I prefer a lateral step down. I don't score stuff. I just watch the movement. So you can standardize it, hands on the hips. We're just watching. Do we have that collapse of the knee? Can they control the movement? Or is it just impossible for them to even do that lateral step down? Do they kind of take their hands off? Do we have a lot of rotation of the pelvis? We're just looking at all of these things to see if they can control it. And you guys might be thinking this is like a really easy screen to do. So this is Mary. I've used this before. She is an Olympic USA weightlifter. She did go to the Olympics in Paris. She can outlift every single person in this room. She came to us with complaints of low back pain, so I had her do the screen. I would probably have her do it on a firmer box, but even someone at that level, you would think would be able to control a lateral step down. She's having a lot of difficulty with this movement. So we know that there's some frontal plane instability with her. And it was the same side to side. She's really struggling with this movement. So it is a good screen to utilize with individuals. It tells me that this is something we need to focus upon. And it makes sense. She trains primarily in that sagittal plane all day, every day. We don't really focus on single leg activities when we're talking about weight trainers at this level. Not a lot of frontal or transverse plane work either. So I would expect this not to be a great screen on her, but it told me where we needed to kind of fill in the gap. So this is one that I would highly recommend that I didn't really do initially either when I was looking at my patients. Bird dog, we talked about core stability or rotary stability, and of course, body weight is going to be the higher version of it. So I'm going to see a lot of things happen if someone is lacking core stability or rotary stability in a movement like a bird dog. So I'm just watching the movement. Mary, when I had her, I don't have the video of it, she had excessive hip rotation, had a lot of movement out to the side, and she also struggled with controlling the movement. So that was quite interesting to see as well. That told me we needed to work on rotary stability and core stability with Mary. Active straight leg raise, I like this one. Obviously, it's from FMS, right? We're looking at dynamic hip mobility. We're looking at motor control of the trunk and pelvis as well. So this is another one that we're gonna really be able to tell if there's some things that we need to work on. Again, I am not diagnosing anybody. I'm just saying, hey, that looks like something that we need to work on. This is a great one for hip internal and external rotation. Obviously, some people that have really, really painful knees aren't going to be able to get into this position, but this is just easy to check. Hip internal and external rotation. Can they sit in this position without cringing? Are they lifting up their pelvis? Are they just like, oh, this is painful? Is it the same side to side? Super quick screen to look at internal and external rotation. Again, most people are going to have deficits in internal rotation when we're talking about hip mobility. Now, I'm actually way ahead of schedule, sorry guys. Putting this all together. So we need to look outside of just the knee joint. That is my hope for you guys, that you walk away and go, okay, at the very least, I'm gonna start looking above and below that joint, instead of just focusing on that knee joint and just focusing on VMO or quad strength. Because I talked about quad strength, VMO strength, really isn't a big deal. I'm not too concerned with that. It's more about how all of those muscles are working together. And I'm not focused on the strength of one individual muscle. So whatever the hip and the foot tell the knee to do, it's going to do. So focusing on foot stability when we're doing a lot of exercises, being mindful and have intent with what the foot is doing can change a lot about how someone can control a movement, whether it's a squat, a lunge, a hinge. You can get people out of shoes. You can tell them to grip the ground with your feet, feel the ground with your feet, push through the feet. These are all great cues that people often miss. So the same with the step ups and step downs. I like to get people out of their shoes because big bulky shoes, you don't have a lot of ability to kind of really feel what's happening at the foot. And for me, I can't do step ups or step downs if I'm in my shoes. Can't do a lot of single leg work because I do have that meniscus tear. So I have to be really aware about what the foot is doing. So again, foot and ankle mobility, dorsiflexion, screen. You don't have to work on ankle mobility if there's not an ankle mobility issue, but we need to know if there is one, because you saw the effects of if we're lacking ankle dorsiflexion, what can happen to an individual, especially when we're operating at high levels with athletes. That is one place I would check all the time, is just to make sure. If their ankle mobility is fine, then I wouldn't worry about it. We can still work on foot stability and things like that. Hip mobility. Talked about how internal rotation, deficits in hip internal rotation can lead to knee injury. Again, let's screen. We can work on hip mobility if we know it's an issue. Hip mobility is an easy one to fix, especially if we're adding in core stability. You're gonna see huge improvements with hip mobility if you combine core stability. There is a lot of research with that as well. So the musculature of the hip is key. So instead of just sagittal plane-based exercises, let's focus on single leg exercises. Let's focus on frontal plane stability, frontal plane strength. Eventually, we'll progress into that transverse plane. We're not going to do any transverse plane work in the hands-on today. We'll probably resist some of the transverse plane, but not actually move through it today because that is a little bit higher level. Core stability. Core stability is key with everything, and this is just not with the knee. This is going to carry over with pretty much every body part, contrary to anything what anyone says. So it's going to help with low backs, it's going to help with shoulders, it's going to help with hips, it's going to help with knees. We really need to understand if someone has the ability to create core stability. A lot of times, individuals don't. My patients rarely know how that's supposed to feel, what they're supposed to do. So we can utilize a lot of tools and give them that feedback to create that core stability. Integration versus isolation, we talked about that. I want you guys to really take a much more integrative approach instead of an isolated approach. So that kinetic chain rehabilitation, that was really key, right? Foot, ankle, hip, core, trunk, even trying to get the upper quarter involved into a lot of these exercises. That is going to be very helpful when you're starting to program certain knee exercises. So I think that, so I do have a lot of knee programs. If you guys are interested, you're more than welcome to check them out. You're more than welcome to email me with any questions at all. I'm always available. I always answer any emails that you have. I want you guys to understand too, we do have a hands-on that we're gonna go over a lot of this stuff, where we're gonna talk about the whys. I'm gonna kind of arrange it where we have ankle mobility, hip mobility, core stability, frontal plane strength. We're gonna go through squat, hinge, and lunge as well, how to better problem solve working with people with knee issues, all the way from really easy to a little bit more advanced as well. So hopefully you guys can come to the hands-on.